Hello, I would like to welcome everyone to today's Systems for Action Research in Progress webinar. Our theme focuses on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And the title of our presentation is Community Complex Care Response Team to Improve Geriatric Public Health Outcomes. I'd like to go ahead and introduce myself as Dr. Shauna Moore. I am the Director of Dissemination and Research Development for the Systems for Action National Coordinating Center. And our presenters today will be Drs. Carolyn Pickering and Dr. Christopher Maxwell. I'd like to go ahead and introduce everyone to the chat box in your lower left-hand portion of your screen. If you have a question or a discussion comment, please type it here at any time throughout the presentation, and we will address those at the end of the presentation. I'd like to go ahead and introduce our speakers. Dr. Pickering's program of research is on elder abuse and neglect prevention and aims to understand the dynamics and development of abuse, neglect, and high-risk caregiving in order to identify effective intervention strategies. Clinically, Dr. Pickering's expertise and training is on geriatric nursing with an emphasis on public health, with past experience as a long-term care ombudsman. Dr. Pickering is a member of the University of Texas Health Science Center at San Antonio School of Nursing, Caring for the Caregiver program, which aims to help support the local community's caregiving needs through research, service, and practice. Dr. Maxwell's research, scholarship, and engagement activities largely focus on understanding and improving how governments and non-government organizations can prevent and control intimate partner violence and violence against women. He currently serves as a co-investigator of the National Institute of Justice's sponsored evaluation of the Domestic Violence Homicide Prevention Initiative. Dr. Maxwell is professor in the School of Criminal Justice at Michigan State University. And now I'd like to go ahead and hand the program over to Drs. Pickering and Maxwell.
Hi, everybody. So I am Carolyn Pickering, and I'll be telling you today about the results of our Community Complex Care Response Team, or CCRT, pilot program. If you've been watching these seminars from the beginning, you've seen us talk about the intervention, about the implementation evaluation, and now we are on to our evaluation of our key outcome measures for the project, which is what we'll be sharing today. So this project started as a real community-based effort, and it's been going on for several years. A local community group of different service providers were looking for ways to better assist older adults who are at risk of experiencing abuse and neglect, or who were experiencing abuse and neglect, by rethinking how they delivered and provided services. So a quick background, if you're not familiar with abuse and neglect of older adults, about 11% of community-dwelling older adults report past-year prevalence of abuse or neglect. And we know that it's related to an assortment of poor outcomes, such as financial crimes against older adults, which cost an estimated $2.9 billion in 2010. We also know abuse increases threefold the risk of hospitalization. But despite this prevalence and the array of outcomes, we don't have any evidence-based protocols that either prevent or reduce victimization. To be clear, there's a number of programs and services out there to support older adults and elder abuse victims. But what we've been lacking in the field is rigorous evaluations of protocols, and specifically ones that aim to prevent or reduce victimization, which is where this project came in. So in discussions with community agencies, when they discussed how to better respond to this problem and better support older adults in the community, they decided really one of the main obstacles was the ability to share information with each other and to work together, with the idea that if the different multi-sector providers could participate more in shared decision-making and more communication and referrals with each other, that they'd be able to provide a better set of services and a better service experience for the older adults. With that, the CDC and the National Research Council, in their definition of elder abuse, they include vulnerability of an older adult as a key factor, wherein vulnerability is defined as the physical, financial, or emotional dependence on others or an impaired capacity for self-care. So in designing this, this community-based coordinated model, this is what the model was really designed to target, was the idea that if we could increase the independence of older adults and support their capacity for their own self-care, we thereby reduce vulnerability and their experience of abuse and neglect victimization. So with that, the overall program CCRT's goals and aims include to impact the social determinants that contribute to community-dwelling older adults' vulnerabilities, to identify and align services that primarily address an older adult's capacity for self-care, and to do this through this comprehensive multi-sector service model using a coordinated case management approach. So a quick overview of the intervention before I get into our evaluation. It consists basically of three parts. So we have referral partners, and in this particular round of the project, this included the police, EMS and ambulance, and then the local emergency department and inpatient discharge planners, who, when they identified vulnerable older adults who were either experiencing abuse and neglect or at risk of experiencing abuse and neglect, can refer into the program to the high-risk case management partners. And then that arrow on the screen looks so tiny, but that's really where most of the magic happens, so to speak. So the referrals came into the local area agency on aging that was the leader for the team and this case management process. And when they got the referrals, we had a fantastic community health worker who would start implementing the CCRT program, which included doing a home visit with the older adult, in which she used motivational interviewing to work with the older adult to identify their person-centered goals. And this goal plan then served as the basis for the case planning and referrals with the rest of the team. So after having that, then the community health worker could go back to the team and, using a custom record system, which was built for this project, was able to enter case notes and start initiating some referrals and communications between the other partners. And so the partners all got to share this case record system between agencies through the use of a uniform consent form that was designed for the project. And in doing that, they were able to offer comprehensive service planning and delivery of a variety of multi-sector services that were available in the community. With some key features of this record system and the process was that it provided for information exchange between the different service partners, that loop back communication, and as well as shared decision making. So for the design, our evaluation design for the CCRT pilot program, we used a randomized controlled trial, and this is an overview of the case flow chart. So we had those referrals come in from our referral partners. And step two was intake, where our team member at the area agency on aging would do screening, the initial intake, and consenting, as older adults needed to consent to wanting services in the first place before they could be assigned to a service. From there, they were randomized either to receive the intervention, which was C3RT, or they went to standard care, which is INR. INR is Information and Referral Assistance. It's a program that's offered pretty standard through area agencies on aging throughout the nation. For INR, you can call in if you are looking for help with a certain need, or you're looking for a service provider, and INR can help identify different agencies and provide contact information for you. So by comparison, INR is a pretty passive approach, whereas CCRT, we had much more active and hands-on, where the community health worker would go to the house and work through that person-centered plan, and then from there help to address a variety of needs by actively, when appropriate, working on the service enrollment on behalf of the older adult instead of just passively providing information and stepping away. So our key process and outcome measures. First, the intervention itself, we intended for it to work by increasing referrals for services, increasing service enrollments, and increasing the communications between these different community agency service providers. And then our key outcome measures for the clients were that we'd have fewer or delayed contacts with the police department, with Adult Protective Services or APS, and fewer delayed hospital admissions. So our intervention sort of pipeline, we had 159 clients that were referred to the Area Agency on Aging for this program. By and large, most of the clients came from a hospital staff, which included the ED and inpatient discharge planners. Of those, 96% were eligible to receive services. And then from there, we had 146 clients that were assigned to either the CCRT intervention or INR, which was standard care comparison. So this table is just showing the demographics between the different groups. Though it looks like, just by percentages, that the CCRT group was perhaps a little more at risk. It had more women and more ethnic racial minorities and more agency contacts in the prior year. Statistically speaking, there were no significant differences based on demographics between the two groups. Okay, so now onto our process measures. So for intervention dosages, we, like I said, we thought that the intervention or intended intervention to be working by increasing referrals, services, and communication updates. And we did see that for those who were assigned to C3RT, did have significantly more average number of referrals, as well as percentage clients with referrals, significantly more services provided compared to the standard care group, as well as percentage folks with services provided, and that those in our intervention group had significantly more communication updates compared to those in standard care, where communication updates refers to updates between the different providers about the case itself. So then we wanted to look at the different types of services, because this was reaching across multi-sector service agencies to see where our CCRT intervention clients were being referred to compared to the standard care. Though while across most categories there were more referrals for CCRT, we saw that there were significantly more referrals made to Meals on Wheels and to the PERS program for clients in C3RT compared to standard care. And PERS stands for Personal Emergency Response Systems. So those are those you need help buttons. So we had significantly more C3RT clients referred to that program in Meals on Wheels. Okay, so on to our key client outcomes. The first outcome of interest was victimization recorded by the police or police contacts. And we found 7% of all clients enrolled had one or more police contacts after a group assignment. The second was APS case investigations were opened. So not just a referral to APS, but that APS reviewed the case and decided to open an investigation. And so we had 12% of our clients with one or more APS cases opened after a group assignment. And then hospital admissions, for this the sample size is only 44, because while we were relying on systems data for all these outcomes, for the hospital data we needed a signed HIPAA waiver, and that proved a little challenging to get. If you've seen our previous webinars, I think we've talked about the variety of ways in which we've gone about trying to increase our number of signed HIPAA waivers. But to date with this analysis, we have data on 44 folks. And so of those 44, 75% of clients had one or more hospital contacts after a group assignment. Okay, So for our outcome models, we used Cox regression survival analyses, which included two key extraneous measures, both the client's sex and the client's prior contact with the reporting agency. And so for our first outcome measure was the police contact, or a police department with PD. So we saw that those assigned to C3RT, though not statistically significant, did have about a 20% higher relative risk compared to those in the control group of having subsequent police contact. The risk was also higher for males, and we did see a significant higher risk for those who had victimizations in the year before enrollment. So in other words, if you were a victim prior to enrollment, you were at a higher risk of being a victim after enrollment. This is the hazard function or hazard rate for the police contact model you just saw, where it's showing you that given up that you lived or succeeded up till today, what is the likelihood that you were going to fail or have a police contact tomorrow? So our next outcome was APS case investigation. This time we did see that those assigned to the CCRT intervention had a 35% lower relative risk of having a subsequent APS case opened compared to those in the control. So again, this was not statistically significant. However, it was going in the direction we hypothesized. Again, we saw males at an increased risk, and that the number of open referrals the year prior to enrollment was significantly related to an increased risk after group assignment. So again, victimization before group assignment, increased risk of victimization after group assignment. Then this is the hazard function for our time to first open APS case, wherein the C3RT or intervention group is that red line. So then our third outcome was the hospital contact, and that included both either ED or inpatient admissions. Again, we did see that those assigned to C3RT had a lower relative risk, about 20%, compared to those in the control group of having a subsequent hospital contact, though again, not statistically significant. We did see that subsequent contact did predict or was significantly related to an increased risk of a hospital contact after group assignment. And then this is the hazard function for the time to first hospital contact. And again, this only includes the 44 participants for whom we had the signed HIPAA waiver on file for. So we also added an alternative outcome measure. In our quest to get our HIPAA waiver form signed, we did learn that a number of clients enrolled in the study actually passed away. And so we decided to look at the rate of mortality post-intervention. 27% of our enrolled clients died during their follow-up period. 35% of those were in INR, and then 19% of those assigned to C3RT. So when we did the Cox regression model, we did see that actually those who were assigned to receive the C3RT intervention had a significantly lower risk, a 50% lower relative risk of death post-assignment compared to those in the control group. And interestingly, unlike the other models, the number of victimizations in the year before enrollment was not significantly related to the mortality after group assignment. And then this is the time to death analysis, where again, that C3RT group or intervention group is that red line on the bottom. So we had planned to enroll 300 clients, but we only ended up enrolling 146 after we even extended the enrollment period by 3 months. This was primarily related to a lack of referrals from police and EMS, which didn't materialize as planned. These partners were rather involved in the early stages of this pilot program and in the planning for this evaluation, so we had reason to believe we'd have more referrals, but it didn't end up working out that way. We did find that implementation of our random assignment protocol was robust. We had 2 statistically identical comparison groups for the analyses. For our process outcomes, we did see C3RT produced more referrals, more service enrollments, and more communication among service providers compared to the standard care. Outcomes across 2 of our 3 key client measures pointed towards improvements due to assignment of C3RT. However, they didn't reach traditional levels of statistical significance, though clinically speaking, there might be relevancy in those risk reductions. We did see a significant improvement in lifespan among our C3RT clients, and we did check to see if this was related to receiving a specific service. As you might recall in one of the first slides, those in C3RT, the C3RT group had a significant higher number of referrals to the Personal Emergency Response Program and to Meals on Wheels. So we checked to see if either of those were driving this effect we saw on lifespan, but they were, it was not. Lifespan was independent of that, and therefore we believe related to group assignment to our C3RT intervention program. So some discussion points, I guess, that kick off our Q&A here. So not statistically significant. C3RT did reduce APS recidivism better than APS alone did, which is something we think is worth looking more into. APS exists in every state, so the programs themselves are highly variable from state to state as they're state run. So again, in Michigan, where we did the study, we did see a reduction in recidivism, and it'd be worth looking at in other regions. We are working on Medicaid data to assess the impact of C3RT on nursing home placement. Knock on wood, hopefully we're expecting the data transfer any day now. But we wanted to see both because nursing home placement and early institutionalization is an outcome we would like to prevent if in the spirit of supporting independence and capacity for self-care, we hope that we would be keeping folks out of nursing homes. But we also want to look at that outcome to make sure we didn't just displace people into the nursing home system, and that might be why we're seeing lower rates of APS cases, for example, or lower rates of hospital admissions, for example. We are also exploring whether this lifespan extension was related to all-cause mortality, and we're seeking our death certificates to do an all-cause mortality analysis. And then lastly, our kind of next steps, as this is Systems for Action, we were looking at these system-level outcomes, increasing communications between providers, looking at overall system contacts. But now we'd like to look more at some, I suppose, victim-centered outcomes. And so through an evaluation funded by OVC with the local community partners, we are planning to do more investigation from the victims' perceptions, their reports of their victimization, as just because they didn't have contact with the system, like police or APS, doesn't mean they weren't being victimized, because a lot of violence doesn't get reported. As well as to learn more about other sorts of outcomes that we might have impacted, such as our capacity for self-care, self-efficacy, and social isolation, to see if those might be related to some of these positive intervention effects on lifespan. So I believe that brings us to questions.
All right. Thank you, Dr. Pickerington, for reporting on this interesting subject. I know Dr. Maxwell is on the line. Dr. Maxwell, would you like a few moments to comment or provide any thoughts before we go into our discussion and questions section?
I just would say that we are going to continue to do some analysis on these data. We're particularly going to look at whether the intervention prevented the onset of victimization versus reducing the level of victimization among active victims. I think that there's some promising analysis we have that shows that there might be we might be having one type of effect more than we're having another, and we want to look at that with the APS as well to see whether we're preventing onset rather than as a significant effect. So we are going to look some deeper at some of this data, and then we hopefully, with the additional support we've gotten from OVC, we're going to have some more cases that we'll be able to do some more analysis on a larger sample sometime soon. That's about it.
All right. Thank you very much. So a question just came in on restating what CCRT is, and we've already answered that, but I'm just going to go back to your opening slide so people can refer to. It's the Community Complex Care Response Team program that you have looked at. And I had something that can get us started. So I had seen that you expected to originally enroll about 300 clients that included those in police and EMS that you were not able to get enrollees. Is that correct?
Yes.
Okay. So I was thinking maybe you can talk about how you expect your project to be improved if you could have enrolled these individuals from these various population areas. And you were just talking about focusing on victims. Do you think that if you were able to enroll from these two areas, police and EMS, that would be the population to do more research on these specific victims, or do you think that would come from another area?
Well, to start with the first part of the question, some of our difficulty, you have a great, champion at an agency who's very supportive, and then they retire on you.
Yeah.
Got to start over. With AMS, though, in hindsight, you kind of want to be like that. But when we were all in the room planning this, it didn't occur to us how much overlap there was with EMS and police and EMS and the hospital because, ambulances go somewhere. So a lot of the times EMS, we were getting feedback that, well, most of the time they're going to the hospital, they're just going to let the hospital do the referral. So in that regard, that makes sense. If we had more referrals from the groups, we were hoping to do more of a comparison by referral source to see if those who primarily interacted with police, who came in through the police, if they benefited more or less as much as those who came in referred through like the hospital or EMS. But obviously, since we did not have those numbers, we weren't able to do that.
Mm-hmm. So where do you think you could get? Yeah.
Well, just like to add that probably the most disappointing part of this project is the issue about referrals from law enforcement and EMS. We took lots of steps. We printed posters out to hang in their break rooms with instructions and to do the referrals. There was a app that was developed for their phones. We trained officers multiple times in their roll calls. So I think if one of the things we need to do much more on in this area is how to engage more with and encourage the primary responders to be able to do that warm handoff to services that are available. As Carolyn noted, the initial development was heavily influenced by law enforcement's needs or requests to have a service program like this. And so a large part of the initiative was to address their desired help. So I think that's something we need to figure out a lot more about why we couldn't get that to transpire as much as we had hoped. And that's in large part why the numbers are way down than what we had expected.
Well, the good news, being that you have conducted this pilot, you can certainly show the benefits. So there's certainly opportunity to engage them in the future, I think, with the work that you've done. But I was just curious about, going back to your discussion question to wrap up. So you were going to look at victim-centered outcomes. How do you think, or where would you draw from to find maybe this type of individual that you all would like to serve?
I'm not sure I'm understanding your question. Do you mean to get the outcomes from, or just an overall population? Okay. Oh, so
well, originally I was looking at the population, but I like that you were going to plan for victim-centered, and I was just curious who else you'd like to engage, maybe another community partner, or expand on the populations you've already enrolled.
That's a good question. I think one of the things that surprised me is just how, I guess, really frail the population was, especially, I don't know, I guess I do have a geriatric nursing background, so I was not expecting folks to be in such high crisis, being that we were getting referrals from a variety of sources. Some folks in crisis I anticipated, but it seemed like we ended up in a particularly, I guess, unstable or high risk, high need sort of a population. So in that regard, it feels like we were probably are serving the right folks, the folks that were have the most going on and the most level of need are probably really the ones most at risk for victimization. As far as other partner agencies, we've had a variety of efforts through the project. I think we presented on in previous webinars, and the other component of this was looking more at implementation and implementation outcomes and next steps forward, and how we can have more of a sustainable system, both in terms of like the record system technology component, but also I guess an overall process. And so if you would like my wish list, I think if we could sort out mental health providers better, they had their own obstacle, as we talked a lot in previous talks about data sharing and HIPAA and privacy laws and non-HIPAA and all the variety of number of restrictions on agencies. The mental health code was just a whole extra layer of barrier when it comes to data sharing and their processes. So that's going to take some more work through, but I think had, just from conversations with our great interventionist, our community health worker, she's relayed that there's really a pressing mental health burden in this the population she was working with, and actually a surprising number of folks with addiction problems as well. So having a more of a way to get mental health providers integrated into this, I think, would be a great addition to the program.
Yes. No, I appreciate that. I think that's an excellent idea. Okay, thank you. I do have some questions we can address. So the first one is, could you discuss any thoughts about the impact of time to referral on outcomes? So we're showing this question in relation to your referral time slide. So if you could, okay, perfect. So if you could discuss that. Any thoughts about the impact of time to referral on the outcomes?
Yeah, I saw that question pop up. That's an interesting question. One that we actually could probably do because we have timestamps for everything. My suspicion is that we probably had a reduced time to referral for the CCRT group, particularly because part of this model with a community health worker is that she was really keeping an active, monitoring, making sure referrals were going through and services were being enrolled, and if not, why, and following up. So I suspected shorter, but I also suspect that active monitoring to make sure the referrals were completed was probably also part of the benefit.
Okay. No, excellent. All right. Let's see. So here's another question. So since sometimes the abuser could also be a gatekeeper for the patient, could you engage the patient via the case management office of the facility if the abuse or neglect is suspected without violating privacy laws?
Oh, so that's actually not so much what the obstacle is. The obstacle is the mental health providers sharing information with other service providers, and the extent to which they can share and the level of documentation they need, allowing them to share the format which they can share the data in, like the time the data can be stored, those kind of real, I guess, procedural sorts of details. That's actually more of the barrier that we're trying to work through.
Okay, no, that's really interesting. Okay, so we've addressed the question, so I want to encourage people, because I do have another maybe discussion that we can talk about for a few more minutes, but if you do have any other questions or comments, please type them in. So I really like that you added the additional outcome measure on looking at those who had passed away or your mortality outcome group. So I was wondering, with your new outcome measure, if we can learn from these individuals. It sounds like you're really interested in doing that because of the rate that appeared through the study. So do you think that maybe with the information on the individuals, if you have demographic information or some background information, that you could tailor C3R2 even further to improve against mortality in program participants? Is that the goal there?
Yes, partially. I think also, on the one hand, we were, I think, really surprised at the finding.
Yeah.
Not that I didn't think that it was having an impact, just on such a short time frame. This was a 2.5-year follow-up period, and that we saw such a 50% reduction in relative risk was, I thought rather astounding, and speaks to the work the agencies were doing. So I think being able to tailor it a bit more, and learning a bit more about what were like those real, I guess, active intervention ingredients that were impacting that outcome, since we didn't exactly, in our hypotheses, we were targeting independence and capacity for self-care, which should, I guess, expand lifespan if you're better at self-care. But to go back and find out what really are those key ingredients of the program that are doing that. I will tell you, I did a rather unsophisticated search of social determinants and lifespan, and I could not find anything on PubMed discussing the two. So if anyone in the audience knows of some papers and wants to send them in that chat box, I'd be quite grateful, because I was trying to figure out comparatively how this goes with other sorts of programs, if others have been able to demonstrate impacting social determinants and having an effect on lifespan. So since I preliminarily couldn't find anything, we really want to be thorough in figuring out what this effect is being driven by in the intervention.
Yes, I think that is really interesting. So we can encourage any of our listeners to email you if they have any information for you after this webinar on that, because it's sometimes interesting how this study can actually expose even more information that we can learn. I think this is an excellent example of that. So I want to thank you for your comments and your feedback. So it looks like we're going to end early today. There is actually no more questions or comments in the box, and we'd like to encourage our participants to go ahead and reach out to Drs. Pickering and Maxwell after this webinar if you have any questions or comments regarding this study. And I can go ahead and end with that and introduce our upcoming webinar on March 27th. We'd like to encourage everyone to visit us at systemsforaction.org /research in progress webinars on March 27th at noon to listen to Mariana Chilton and Sandra Bloom speak about integrating behavioral health with TANF to build a culture of health. And also encourage you to go to our systemsforaction.org website to view and listen to this presentation and past presentations. So with that, I'd like to go ahead and acknowledge that Systems for Action is a national program office of the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. Again, I'd like to thank our presenters today for this interesting topic, and I look forward to seeing you virtually on the next webinar. Thank you, everyone, and have a great day.